Many have dreams to be a medical professional. When choosing an institution for medical school, a lot of things matter. The quality of the academic and clinical programs, as well as the clinical experience. At UNIMAS, we offer that and more. A supportive culture, a vibrant community, diverse student and patient population, all set against the backdrop of Kuching and Kota Samarhan.
The culture here is welcoming. It is a big family. Everyone wants the next person to succeed together. We want our students to reflect back to the society and the community today. As a community-driven university, we believe that immersing themselves and ourselves in the diversity, it creates better innovation and greater creative achievement.
In UNIMAS, there's not a culture of a competition here, but a great environment is what we all strive for.
Everyone is committed to create a great environment to become a great doctor in the future.
Our patient population in Malaysia is remarkably diverse. Different languages and dialects will be something that we face every day once we become a doctor. So, getting to know this and learn it now make us to be more appreciate and respect. It just set us up to become a better doctor for the future.
From the beginning of the program, 25 years ago, we have adopted a spiral curriculum. As the students advance forward into their years of clinical study, we connect everything back to underlying basic biological sciences. We connect and revisit every aspect of human health, from emotions to diseases, back to its basic biological sciences.
We are introduced to clinical setting early in our curriculum. The exposure gets more as we advance through the year. It was very daunting at first, as a first-year student, to step into hospital and seeing patients. But at the same time, it's really an exciting experience.
We are committed to excel in nursing education, research, and practice. It views health as a complex and dynamic, and the client as a holistic individual. Students in this program learn in an environment that stimulates intellectual inquiry and creativity, which encourages them to be problem solvers and lifelong learners.
Here, we learn how to care, to serve, and to help. We went from zero to hero.
I really cannot pick a better place to learn and become a greatness. This is a place that belongs to my heart throughout my journey.
Come do research with us.
Come and join us at UNIMAS and realize your dreams.
Set. Okay. Ladies and gentlemen, a very good morning. I wish you all a warm welcome. I'm Dr. Jiwin, a general surgeon from the Department of Surgery, Faculty of Medicine, Health Sciences, UNIMAS, Kuching, Sarawak, Malaysia. First of all, I would like to express my sincere thanks to the organizing committee for their excellent efforts in making this first FMHS Health Talk Series 2022 really happen. And also thank you to all participants who join us today and spending your time with us. It's my great pleasure to introduce our prominent speaker, Prof. Dr. Sim Sikiat, a well-known neurosurgeon from the Faculty of Medicine, Health Sciences, to you all. Prof. Sim achieved his MBBS from University Malaya in 2006. He obtained his master's degree in the field of neurosurgery in 2014, and he is also a life member of Neurosurgical Associations of Malaysia with a keen research interest in neurotrauma and neurorehabilitation. And also, Prof got a fellowship in spine surgery as well. Today, Prof Sim is going to talk about brain bleeding in the elderly, especially he will focus on chronic subdural hematoma. The first session will be given to Prof Sim and subsequently followed by questions and answer section. All the participants are requested to type your questions in the Q&A box, and we will try our best to answer all of your questions. So without further ado, let me welcome Prof. Sim to deliver the talk. Prof. Sim, the floor is all yours. Thank you very much.
Thank you, Dr. Chi Wing, for the kind introduction. Good morning to everyone. Welcome to UNIMAS Faculty of Medicine and Health Sciences Health Talk Series 2022. I'm Dr. Sim, neurosurgeon from Department of Surgery, Faculty of Medicine and Health Sciences, UNIMAS. This morning, we are going to discuss about chronic subdural hematoma, which is one of the common brain bleeding conditions in the elderly. For subdural hematoma, it can be classified as acute or chronic types. The acute type is more commonly seen in the younger patients related to traumatic head injury. For example, when the patients are involved in a car accident or accidentally fall from the height or hit by any hard object. Whereas the chronic type is more commonly seen in the elderly and can be happen without any obvious contact head injury. In this health talk, I'm focusing on the chronic type, and I will explain to you the basic anatomy of the meninges, causes of the subdural bleeding, the risk factors, the presenting symptoms, the investigations, and the treatment. Should you have any questions during the talk, please feel free to ask in the chat box. Now, let's take a look on the basic anatomy of the brain. The brain is protected inside the skull. If we remove part of the skull bone, as shown in this model, then we will see the brain. However, we are not going to see the brain surface directly like this after we remove the skull bone. This is because the brain surface is covered by the membranes called meninges. Thus, there is no direct contact of the brain surface and the skull bone. And the main function of the meninges is to cover and protect the brain. When we are looking in detail, the meninges are in fact made up of 3 layers, namely the dura, the arachnoid, and the pia matter. The dura here, the arachnoid is here, and the pia matter is here. In this picture, the outer layer of the meninges, which is the dura matter, has been cut and lifted. The dura matter is a smooth, thick, strong, and dense membrane, and it is light yellow in color. Whereas the other two layers, the arachnoid and pia matter, are very thin and they are transparent. They are closely covering the brain surface. This is the real brain specimen. This is the dura matter that has been cut and reflected. Here you can see the brain, and you can see that the brain surface is very shiny. This is because the transparent arachnoid and pia matter have given the brain surface this shiny look. Now, let's look at this picture. This gray color area is the skull bone, and this light brown area is the brain. As what we have discussed just now, in between this skull bone and the brain is the meninges. And the meninges consists of three layers: the dura, the arachnoid, and the pia matter. And the space in between the dura and the arachnoid is called as the subdural space. This is the subdural space. In simple, subdural means below the dura. Since this space is below the dura, thus it is called the subdural space. The importance about this subdural space is it contains vessels, the blood vessels, which are called as the bridging veins. This is the bridging veins, and there are a lot of bridging veins inside this subdural space. This bridging vein mainly drains the blood from the cerebral cortex into the superior sagittal sinus. Superior sagittal sinus through this subdural space as well as within the dura. So what is subdural bleeding? Basically, it means bleeding into the subdural space. And in fact, the bleeding is outside the actual brain tissue, not inside the brain tissue, but outside the brain tissue. And how does this subdural bleeding occur? It occurs when there is a tear in the bridging vein. Then the blood will leak from the torn vessel into the space. Another term for subdural bleeding is subdural hemorrhage. And the collection of the clotting blood in this space is called as subdural hematoma. So hemorrhage is the process of bleeding, whereas hematoma is the collection of blood. Why this chronic subdural hematoma is more common in the elderly? When we are getting older, not only we are losing the muscle bulk, but similar condition happens in our brain as well. Our brain is shrinking or getting smaller when we are aging. When we get older, our brain getting smaller. And thus, we are losing our brain volume. This condition is called as cerebral atrophy or brain atrophy. In the cerebral atrophy, this subdural space will increase, getting larger because the brain is shrinking. That's why the space getting larger. When the space is getting larger, this will cause more stretching on the bridging veins. And this makes the veins more likely to bleed after a head injury. In addition to the stretched veins that we have learned just now, the elderly has a weaker vessel wall as well, and thus more susceptible to injury and bleeding. And these two reasons that I have explained why chronic subdural hematoma is more common in the elderly than other age group. And even a minor head injury can cause chronic subdural hematoma in the elderly. In addition to the elderly age, people who are misusing alcohol or chronic alcohol drinker, they are at risk as well. Excessive alcohol drinking can injure the liver and cause blood clotting disorder. It also can accelerate the process of brain atrophy, and they are more likely to fall due to drunk and unsteady gait. In addition to this, people who are on anticoagulant therapy, they are also at risk of developing this chronic subdural hematoma. The anticoagulants are usually prescribed for patients with heart disease or stroke. The common examples are aspirin and warfarin. These medications may cause bleeding more likely after a head injury. Now, we are going to see the effect of chronic subdural hematoma on the brain. On the right side diagram here, the green color represents the dura. The blue color represents the arachnoid layer. And the subdural space is filled up with liquefied blood, which is in red color in this diagram. Unless it is a very obvious and impactful head injury, like what we see in the acute subdural hematoma, otherwise, the initial bleeding will be very slow in this chronic type. Since there is a brain atrophy, the brain is still able to accommodate this accumulated blood without any symptoms in the beginning. Means the patient will not have any symptoms in the beginning. The patient will not complain of anything in the early phase. And the blood will slowly build out and slowly cause pressure on the brain surface. And slowly the symptoms appear. Usually the symptoms only appear 2 to 3 weeks following the initial injury. That's why it is called as chronic, because it is not immediately causing symptom. Now, let us look at the left-sided diagram here. This is a CT scan of the head. when we are looking from the top. This is the right side and this is the left side. The right side is the normal side, where we can see the structure of the brain surface very well. We can see the sulcus here, and we can see the gyrus here. But on the left side, we can see a precentric shape, which is relatively darker or black color compared to the adjacent brain tissue. Here, this precentric shape is actually the chronic subdural hematoma that has been liquefied. And this blood collection has compressed and pressure on the brain surface. When you compare to the opposite side, here you cannot see the structure of the brain surface clearly at this side. You don't see the gyrus, you don't see the sulcus, but it just appears flat because the chronic subdural hematoma is pressing on the brain surface. And the bleeding can actually happen on the both sides. In this CT scan, this CT scan is showing bilateral chronic subdural hematoma. Bilateral means both sides. You can see here on the CT scan, both sides, the brain surfaces are all flat. They are all being compressed. We can't see the structure of the brain surface well. They just appear flat. And this side also appear flat. And this is the chronic subdural hematoma. And this is the chronic subdural hematoma. And inside this chronic subdural hematoma, you may see some white color segment here. This means there is still recent ongoing bleeding happen. Usually in this type of cases, bilateral chronic subdural hematoma, this can lead the patient into comatose. So what are the symptoms the patient has? Due to its slow bleeding nature, the symptoms tend to be gradually progressive, and the clinical presentations is usually 2 to 3 weeks after the initial injury. Sometimes the patients cannot even recall any injury event because the injury can be very minor, not necessarily contact head injury. If the patient is participating in a very aggressive exercise or going to the club and have a hot dance, the patient may end up with chronic subdural hematoma, not necessarily hit by any object. The symptoms include worsening headache, nausea and vomiting. Nausea means the patients want to vomit, but actually they are not vomiting. Patients also will complain of tiredness and appear drowsiness. Some of them will become very confused. They have poor oral intake, loss of appetite, reduced meal taking, which can cause electrolytes imbalance and tiredness as well. Patients may also have personality change, either being unusually aggressive or having rapid mood swings. Patients also can present with symptoms that are almost similar to stroke, such as speech disturbance. Either they have problem to say something, or they may have problem to understand when we are talking to them. The patient may also have vision problem, for example, diplopia or double vision. Patient may also complain weakness on one side of the body, or in the medical term, we call it hemiparesis. Patient can have walking problems, unsteady gait, frequent falls, and sometimes patient can just present with seizure. Seizure means fitting. And in certain cases, they can present with loss of consciousness. There are some other medical conditions that may present with similar clinical pictures. These include brain tumor or brain metastasis, especially in this elderly group, stroke, which can be either ischemic stroke or hemorrhagic stroke, electrolytes imbalance due to poor oral intake, which is quite common in the elderly, and brain infection such as meningitis. For investigation, a thorough medical information and physical examination are needed. We need to do some blood tests to look for any bleeding disorder, especially those with liver problems or those who are on anticoagulant treatment, and also to look for other causes for confusion. For example, electrolytes imbalance or infection. And a CT scan is needed to confirm the diagnosis. Once the diagnosis has been confirmed, then we will need to treat accordingly. First of all, we need to correct the bleeding disorder if there is any, either by giving the platelets or fresh frozen plasma transfusion. And we need to correct the electrolytes imbalance accordingly, if any. And finally, we may need surgery if the patients are symptomatic and where there is altered consciousness, means when the patient appear drowsiness or lethargy or confused, this is called as altered consciousness. Then surgery is indicated. The commonly done surgical procedure is burr hole and drainage. In some complicated cases, a mini craniotomy or craniotomy may be needed. The diagram here is showing a burr hole and drainage. Now, in this slide, I will briefly explain the steps of doing burr hole and drainage. First, we need to locate the site where do we need to make the burr hole. Usually, the site is chosen based on the CT scan, where the hematoma is at the thickest part. We will first make an incision on the overlying skin and use an instrument called perforator to drill through the skull bone until we see the dura. The burr hole is about the size of a 20-cent coin. After that, we will cut through the dura and the liquefied blood will then gushing out from the burr hole. The liquefied blood will appear like engine oil. In certain cases, 2 burr holes are needed. Depends on how much the volume of the chronic subdural hematoma. Next, normal saline will then be flushed into the burr holes and wash out all the hematoma. This flushing step will be continued until the fluid coming out from the burr holes are considerably clear. Subsequently, a rubber tube will then be inserted into one of the burr hole into the subdural space, but need to be careful not to injure the brain surface. The tube will be kept for a few days, mainly to drain the residual liquefied hematoma. Lastly, the skin will be stitched. Here, I have a short demo video to show you, so you can understand better the surgical procedure well, and my teammate will play the video shortly.
Shave is performed, and the surgical field is prepped and draped in usual fashion, including sterile towels, IABAN, and split sheets. A linear incision down to bone is made at the anterior mark first. A periosteal elevator is used to expose the skull. A small Wheatlander retractor is placed, and hemostasis is obtained. Using a high-speed perforating drill, a burr hole is placed at the desired location. Bone edges are waxed, and the dura is bipolared. Attention is then turned to the posterior incision, where the same sequence of events is completed. Once meticulous hemostasis is obtained at both sites, the dura is widely opened in a cruciate fashion at the anterior burr hole first. The subdural hematoma is then partially evacuated. Next, the dura is widely opened in a cruciate fashion at the posterior burr hole. Once both sites are opened, the subdural is fully evacuated using a combination of suction and irrigation. Care must be taken to not damage the brain surface, which should be visible through the burr holes. Subdural membranes may be excised depending on their attachments. Once the hematoma has been adequately evacuated, as indicated by clear irrigation exiting the burr holes, closure is commenced. Meticulous hemostasis is obtained. The subdural space is filled with irrigation. Burr hole covers are secured. A subgaleal drain that runs over both burr holes is placed, exiting posteriorly. The wound is generously irrigated to remove debris and devitalize tissue. The scalp is closed with 3/0 vicryl stitches at the galeal level and staples to reapproximate the skin edges. The wound is properly dressed with bacitracin ointment, Telfa, and Tegaderms.
Itself or electrolytes imbalance following the surgery. And recurrence of the chronic subdural hematoma, we may not be able to wash out all the hematoma completely. There will be some residual inside, and this residual will subsequently develop new membrane with new blood vessel, and this can further cause bleeding, slow bleeding within the hematoma. Over the time, the chronic subdural hematoma will recur. The prognosis of the chronic subdural hematoma is good if the treatment has been carried out promptly. The progress of recovery depends on the severity of the initial presentation. If a patient was brought to hospital in comatose, the recovery may be slow. But if the patient was brought to hospital with just headache or some limbs weakness, then the recovery will be faster. But in general, most patients, they will improve in 24 hours after the surgery. Although most of the symptoms will resolve after the surgery, some residual neurological deficits can persist. For example, patient may have some mind-speech problem or mind motor weakness or recurrent headache. And rehabilitation will facilitate the recovery process and improving the functional abilities. This is my last slide. For this morning's talk, the take-home message is chronic subdural hematoma is a common type of intracranial bleeding in the elderly. A minor head injury can cause chronic subdural hematoma, and sometimes there is no contact head injury at all. Any aggressive exercise may cause chronic subdural hematoma. Elderly persons, chronic alcohol drinkers, or those who are on anticoagulants treatment, they are the group at risk. The symptoms present 2 to 3 weeks after the initial injury. That's why the name chronic comes to. And we need to differentiate chronic subdural hematoma with stroke, brain tumor, or brain infection. The prognosis for the chronic subdural hematoma with prompt treatment is good. However, if the treatment is delayed, it may cause life-threatening condition. With this, I end my session. Thank you for your attention, and please feel free to ask questions if you have any. Thank you very much. Dr. Chi, back to you.
Yep, thank you so much. Can I start now? So can I start now?
Yes, Dr. Chi.
Yeah. Can I? Can I start now?
Yes.
Oh. Okay, Prof. Sim, thank you very much for your excellent and comprehensive talk. So, ladies and gentlemen, Prof. Sim already delivered the talk on brain bleeding in the elderly, or bleeding in the brain in the elderly. And now I would like to bring it to the question and answer session. Let me check the sum of any questions. Okay, I got quite a number of questions in the chat box. Okay, I'm going to read them out one after another. Prof. Sim, may I request Prof. Sim to kindly answer the questions? I hope
please.
some question will be, I think, in your talk. So, but to the respect of audience, I would like to read some of the questions in the chat box. Number one, can chronic subdural hematoma happen without any head injury? That's the first question, Prof.
Yes, it can happen. For head injury, usually we refer to contact head injury, means something is hitting on our head. For example, in the car accident, our head hit on the steering or hit on the dashboard, or someone fall down from the height, the head hit on the floor, or during a fight, someone is hitting the opponent with a helmet, means this is considered as contact head injury. Something is hitting on the head, and this can cause subdural hematoma. But usually this is classified as acute subdural hematoma. In this chronic subdural hematoma, the condition is slightly different. The mechanism is slightly different. Sometimes there is no obvious contact head injury. For example, if an old person, an elder person, he just try to involve in a very aggressive exercise, aerobic exercise, where he needs to move his head frequently and rigorously, this may also cause tear of the bridging vein inside the subdural space, and this can cause subdural hematoma as well. So for the answer, yes, it can happen without any obvious contact head injury.
Okay, thank you, Prof. There are some more questions. Number two, how does alcohol consumption relate to chronic subdural hematoma? Prof.
Okay, thank you. About alcohol, there are few ways to cause a problem within the brain. Number one is the direct effect of the alcohol on the brain. The alcohol can damage the brain cells. Thus, it can cause brain atrophy, shrinking of the brain. Because the alcohol is damaging directly the brain cells. This is considered as direct effect. The other way is, in a chronic alcohol drinker, the blood vessel will become thickened and hardened. This will reduce the blood supply to the brain as well. In a long term, when there is inadequate blood supply to the brain, this may cause brain shrinking as well. This is the number two. And beside the brain atrophy, other side effect of the alcohol drinking on the brain, including they will damage certain part of the brain, for example, the frontal lobe and the limbic system. Among the alcohol chronic drinkers, they tend to develop dementia or forgetfulness. So these are all the side effects of the alcohol. But for the subdural hematoma, the main problem is the direct effect of the alcohol on the brain. It damages the brain cells and causing cerebral atrophy. The process of cerebral atrophy in alcohol drinker is greater than the elderly who did not drink.
Okay, thank you, Prof, for your very clear answer. So may I read one more question?
Yes, please.
If a patient has a stroke before and is now taking aspirin, is this patient at a higher risk of getting chronic subdural hematoma? Yep, that's a question to you, Prof.
Okay. About aspirin or any other anticoagulant, is not causing subdural hematoma by itself. For example, a patient with stroke and need to take aspirin, the aspirin itself is not causing subdural hematoma, but it will increase the risk when there is a bleed. For example, if this patient who is now taking aspirin and at the same time he has a mild head injury, for other people without taking aspirin, maybe the bleeding is very little. But in this patient, the patient who is taking the aspirin, it may cause profuse bleeding. So it increased the risk. Aspirin is not causing subdural hematoma actually, but it increased the risk. And similar to other type of anticoagulant, warfarin, for example, a patient with a heart problem, sometimes they are prescribed with this warfarin. So again, as long as there is no head injury, no rigorous head movement, usually these medications are safe. However, when there is any mild head injury, then the bleeding may be greater than others.
Okay, thank you, Prof. So there's one more question from Suryati, okay? Hi, Prof. Is there any way that we can differentiate between a stroke and brain bleeding?
Okay, how can we differentiate between a stroke and a brain bleeding? From the presentations, sometimes it is not clear. Sometimes we can guess, sometimes it is not clear. For example, stroke. Stroke, we have two types. One is ischemic stroke. Another one is a hemorrhagic stroke. Usually, ischemic stroke, patient will not lose their consciousness. They do not have confusion. Most of the time, they do not have confusion. Probably they have speech problem, they have limb weakness. However, there is no alteration in the conscious level. And this happens suddenly. Whereas in a hemorrhagic stroke, usually it will accompany with drowsiness and lethargy. And this also happens sudden onset. Whereas in this chronic subdural hematoma, the symptoms usually appear gradually. It is not sudden onset. Sudden onset means, for example, ischemic stroke, sudden onset. When I am eating, when I am eating, suddenly I cannot swallow. Suddenly I cannot talk. Suddenly one of my hand cannot move. This is called sudden onset, very sudden. But chronic subdural hematoma, usually the symptoms are progressive. For example, I feel very tired today. Tomorrow, I feel even more tired. And the day after, I can't really move my hand. And the day after, I can't move at all. So it is gradually. So from here, chronic subdural is gradually. Ischemic stroke, very fast, sudden onset. Hemorrhagic stroke, also very fast. But hemorrhagic stroke usually will affect the conscious level. Whereas ischemic stroke, most of the time, the patient still conscious. Just they have some neurological deficit, but they're still conscious. Hemorrhagic stroke, the conscious level will change. Chronic subdural, it will be gradually onset. This is from what we see from the clinical presentations. Means we get history from the patient, we get the history from the family member, and after we examine the patient, we can come up with this diagnosis. However, to confirm the diagnosis, at least we need to do a CT scan. CT scan is needed to confirm or to differentiate this ischemic stroke, hemorrhagic stroke, or chronic subdural hematoma.
Okay, thank you, Prof, for the excellent answer. We have some more questions. Can a patient with chronic subdural hematoma recover without a surgery?
if the patient presented with chronic subdural hematoma, at the same time, there are symptoms, for example, headache, confused, with limb weakness. In this case, we advise for surgery because at the moment, there is no medication that can treat chronic subdural hematoma. We need surgery to drain out the hematoma. If we delay, it may cause life-threatening condition. But if the patient has mild headache without any other symptoms, and through the scan, the chronic subdural hematoma is not that thick, then we can observe first. We can try to observe whether the patient can improve within the few days. If it getting worse, we still proceed for surgery. But if getting better, then we just watch on the patient and proceed with rehabilitation. As a general rule, if the patient has symptoms and has altered consciousness, yes, we need surgery, because if we delay the surgical procedure, it may cause life-threatening condition. There is no medication at the moment that can resolve the blood clot.
Okay, thank you very much, Prof. A very clear, answer. Okay, one more question. What are the chances of surviving the chronic subdural hematoma, Prof?
Okay, in general, usually it happens among the age group of 60 to 70. But sometimes we still see younger patients, for example, at their 40 plus, they still get chronic subdural hematoma. 50 plus, they still get. But majority in the age group of 60 and 70, right? It's more to the group after retirement.
Okay, Prof. Thank you so much. One more question. What age commonly presenting with this problem?
I think I just I think this is it the same question like just now?
This is age of the patient with this.
It's about 60 to 70s.
60 to 70. Okay,
yes,
thank you
60
so
to
much.
70s. Yes.
Okay. One more question from the audience. What are the complications of surgery for chronic subdural hematoma?
Any surgery will come with complications, just no matter whether it's a big complication or small complication. Burr hole and drainage is actually a simple procedure, a very simple procedure. However, it still comes with some complications. It is not common. It is not common and considered rare. The complications can be bleeding, right? Can be bleeding. Although the purpose of doing the surgery is to remove the hematoma. However, it can sometimes happen, the surgery itself cause new bleeding. For example, when we insert the tube, it is too deep and hit on the brain surface, or when we are flushing the saline too fast, this also can cause new bleeding. And the other common complications is infections. Most of the time, the infection is just superficial, just affecting the wound. But rarely it can cause pus collection or subdural empyema, means the pus formation inside the subdural space. These are the rare complications. In general, I will say this burr hole and drainage is considerable simple procedure and considerable safe. Just a minor complication that can happen.
Okay, thank you, Prof, for clarification. We have some more questions from YouTube. Okay, and it is from Annam Balasandram. The question is, has a patient ever fully recovered from chronic subdural hematoma? That's the first question. And what are the chances for a fully recovery?
Okay. Again, this depends on the severity and the condition during presentation. When the patient come to the hospital, we will assess the patient. We will look at the severity. Sometimes the patient come to hospital quite late. So in this case, the severity may increase. Most of the time in general, the prognosis is good. The recovery is good. Even some patients can sitting up and can start talk to you 6 hours after the surgery. The recovery is very good. You can see the obvious changes. Before surgery, very tired, drowsiness, have speech problem, got limb weakness. But 6 hours after the surgery, they can improve a lot. And most of the time, within 24 hours, they can get better. The prognosis is good. The recovery is good. If we want to say the percentage, in general, I would say 80% to 90% is good. But some patients, they present late. For example, they have the symptoms, they have headache, they are tired, they have poor oral intake, but the family member did not notice, or they think it's just a normal tiredness. The patient has been working so hard, now he gets some muscle tiredness. So they did not notice it and causing some delayment. And when the time when the patient reached the hospital, the patient may be already in semi-comatose. So in this case, it will take longer time to recover. And in certain cases, some residual neurological deficit can still persist. For example, limb weakness. Before the surgery, the limb is very weak. After the surgery, yes, we can see some recovery, but it is not as strong as before. There is some residual. This is happen case by case. Difficult for us to say how many percent of patient will get 100% recovery, how many patient will get 80% recovery, because every patients are different. But in general, the recovery rate can up to 80 to 90% if the patients come to hospital on time. If no delayment, the prognosis is good.
Okay, thank you so much, Prof. Very clear information and the answer. One more question from Mr. Mohammed Hussain. Prof, is there any non-invasive treatment for brain bleeding?
So far, no. There is no medication that is able to resolve the blood clot. If the blood clot is thick, causing problem to the patient, we still need surgery. There is some study ongoing. They are using steroid, such as dexamethasone. They use the steroid to treat the patient, but this is still in the trial, and the outcome is also very controversial, because the use of dexamethasone can actually suppress the immune system and the infection rate is high. So there is pro and cons. Usually, we do not use dexamethasone. In our daily practice, we still do not use, but some study center, the clinical trial center, yes, they do give, but the result is very controversy. There is no clear indication for the use of dexamethasone, because the dexamethasone can increase the infection rate. In the general practice, when the patient is presenting with symptoms with a significant volume of the hematoma detected in the CT scan, we still advise for surgery. So there is no medication or non-invasive treatment at the moment.
Okay, thank you, Prof. We have some more time. I think we keep getting some questions. One question to you is, hi, Prof. In health clinic kesihatan setting, when should we refer or indications of referral to neurosurgical department when we encounter elderly with chronic headache?
Okay, so when a patient come to a clinic kesehatan or the health clinic setting, there are few questions we need to screen through, whether the patient has any recent history of a head injury, whether the patient has involved in any aggressive or rigorous exercise recently, is the patient alcohol drinker, is the patient on any anticoagulant treatment. These are considered the risk factors. So when the patient come in with symptoms and with these risk factors, and you are suspecting patient might have chronic subdural hematoma, yes, you can refer for CT scan. You can refer directly. If the patient does not have these risk factors, but appear to have these neurological symptoms, for example, lethargy, weakness, and or speech problems. At the clinical setting site, probably we can just perform electrolytes. Just get the electrolytes test, get the BUS, or get the glucose level done first. If the patient's condition within this few days is not improving, then please refer for a CT scan. Or if the patient present to the clinic setting and they already appear very lethargy, very very obvious neurological deficit, then you can just refer straight without doing the blood investigation. You can just straight refer for CT scan. Mainly refer for CT scan to rule out chronic subdural hematoma.
Okay, thank you, Prof. Prof, there are two more questions left. Number one question is, what are the long-term effects following a chronic subdural hematoma?
Okay, the long-term effect depends on the initial presentation. Most of the patient, they can recover well, but minority, they have recurrent headache. They will have headache, for example, every month they will have a headache attack. But usually this attack of the headache is considered mild. They can just take some painkiller to overcome it. Some patients they present late in the initial, for example, in the initial consultation, they present late. Then after the surgery, patient may have some residual. So residual, we need rehabilitation to facilitate the recovery. But the common long-term effect is headache.
Headache, okay.
Yeah.
Okay, thank you, Prof. This will be the last question. After the surgery, can the chronic subdural hematoma recur in future?
Sorry, again, Dr. Chi?
After the surgery, can the chronic subdural hematoma patient recur in the future?
Yes, it can recur. It can recur. When, especially during the surgery, there are still residual left inside. So in this case, it can start to bleed again. Because the hematoma itself, the residual hematoma itself, it can create new membranes which we call as capsule. It can create new capsules. It can create new vessels. So in this condition, there are tendency to bleed again. So when there is a residual, there is a small chances that this chronic subdural hematoma will recur.
Okay, thank you, Prof. So far, there's no more questions. So,
Dr. Chi, there's another one here.
oh, I see. Wait, Prof, wait for a while.
Yes.
Okay, I see. There's a question from the Facebook. The question is, for chronic subdural hematoma, which is a more conclusive test, CT scan or MRI of the brain?
Usually CT scan can detect already. We prefer CT scan is because it is very fast. It is very fast and it is readily available in most of the tertiary hospital. So it is very fast, very quick, and we can detect on it. But in certain cases, there are some cases which you cannot detect chronic subdural when the color, right? I just now have shown the CT scan. That is chronic. That's why it appears darker compared to the brain structure. But sometimes the color looks almost similar, especially the subacute type. The color of the blood and the CT and the brain structure look the same. Look the same. The color look the same. So in this case, when we are still suspecting, yes, we need to proceed with the MRI. But commonly, CT scan is adequate. CT scan can pick up chronic subdural hematoma. So we do not need to proceed with MRI. Only for certain cases that we are not sure, then we can proceed MRI. But CT scan is adequate. Dr. G, I think just now one question that you have asked, I think the doctor is, I'm not sure it's the doctor, he's asking about the indication to refer to neurosurgical department when we encounter elderly with chronic headache. So I just want to, because I did not see the chronic headache just now. In addition to my answer just now, any chronic headache more than 6 months can order for a CT scan, right? Especially in the elderly, right? In the elderly, more than 6 months, not respond to medication. After 6 months, not respond to medication, you can have a CT scan.
Okay. Yeah. Thank you so much. Thank you so much, Prof. Very clear answer and excellent and very comprehensive. Let me check any other questions left in the chat box. Oh, okay. So far, there's no more question, Prof. No more question. Okay. So I think time is now right. All right. And then I think now we have come to the end of our talk today. And I would like to call the whole event a success. And I'd like to express my word of thanks to Prof. Sim for sharing his expertise over the very, very important topic with all of us today, and also to the all audience for your keen interest, enthusiasm, as well as very active participations. I do hope that the presentation has really been beneficial to every single one of the audience today. I'd like to close today's section of the Fast Health Talk Series 2022 by Faculty of Medicine, Health Sciences, UNIMAS. Thank you very much for your kind attention. Take a good care and have a nice day. And then goodbye. Thank you so much.